All right, good afternoon. This is Dr. HASHASH once again over here, and we are going a little forward today. And I will start talking to you about a question, and this is the week's challenge. A 52 years old woman presents to your clinic complaining of weakness. She says over the past several months she's having a harder time brushing her hair, reaching for the higher objects, and lifting her 12-month-old granddaughter. There's no rash. CPK and aldolase levels are elevated, and say we had a reading of 10,000 in this patient. She undergoes a muscle biopsy which shows lymphocytic infiltration in the endomysial spaces, and she was started on prednisone. Which of the following labs would you be interested in ordering? Is it A, spirometry? Is it B, a chest x-ray? Is it C, a lung biopsy? Is it D, anti-Jo antibodies? Or is it E, anti-Rho antibodies? And the correct answer over here is option number D, anti-Jo antibodies. So what we are thinking right now in this patient, we are thinking about polymyositis and not dermatomyositis, because this patient is not having a rash. What is anti-Jo antibody basically? Anti-Jo is basically a cytoplasmic antibody which is directed against transitional proteins like tRNA synthetase, and another one which goes by the name of anti-SRP is like anti-signal recognition particles, and there are newer ones also apart from them, like Mi2 antibodies or Me2 antibodies, which you see in 15 to 20% patients of dermatomyositis, especially where these patients having acute onset with a florid rash and usually having a good prognosis. But most of the times in our patients who are having polymyositis, the antibody which you really want to look is anti-Jo antibodies. And you have to remember that polymyositis is a diagnosis of exclusion in those patients who are having a proximal myopathy and who are not having usually a rash. Like if you are thinking in terms of dermatomyositis, in every patient who is presenting with complaints of a proximal myopathy, you want to rule out complaints, things like hypothyroidism, hyperthyroidism. You want to rule out Cushing's. You want to rule out whether the patient is having some drugs in the etiology of this proximal myopathy, for example statins, or if somebody is taking cyclosporin. Then you should also think about in context to a paraneoplastic syndrome. These patients may have something called as LEMS, or Lambert-Eaton's myasthenic syndrome, or Eaton's myasthenic syndrome, or myasthenia gravis. But in both myasthenia as well as LEMS, usually the ocular involvement is going to be there. Whereas in our patient, if you'll see specifically, they have written over here, they have not mentioned actually over here about ocular involvement. So that's almost excluding the diagnosis of myasthenia, and no option over here is also matching, or is the one which you are going to order in a patient if you want to diagnose a myasthenia gravis. Okay, like sometimes they may change the scenario and they may give you a picture of a patient in which the muscle weakness is improving as the day is going on and on usually. And if you will go electromyography, that will be showing incremental response, an incremental response. And sometimes they may give you an option that what you want to do in this patient, and the answer is to go for a chest x-ray. You want to go for a chest x-ray if you want to rule out LEMS because of small cell carcinoma of the lung. So this is the way how, just by changing the scenario a little bit, the choice of answer will be getting a little bit different. So this is the way how it works. Thank you.